We're going to discuss what is a tracheostomy and what is it used for. What happens when a tracheostomy is inserted and how does it change the laryngeal mechanism? What is the role of the speech-language pathologist? And what is a speaking valve and how do we do speaking valve fitting? And how to do a swallowing assessment. And at the end, I'll share some resources. All right, so about the anatomy, I'm not going to talk about anything in details. I'm sure you guys know all of this information. We're just going to talk about like basic landmarks that I need you guys to know for the purpose of today's lecture. So we all know that the pharynx is divided into the nasopharynx, the oropharynx, and the hypopharynx. And over here, you can see the velum, which separates the nasal cavity and the oral cavity. Over here is the base of the tongue. And over here is the vallecula, which is a pocket between the base of the tongue and the epiglottis. This is the epiglottis cartilage. Sorry. Sorry. So this is the epiglottis cartilage. You guys can't hear the audio now? Okay, so this is the epiglottis cartilage which deflects when we swallow. Over here are the piriform sinuses, and over here is the larynx, including the vocal folds where we phonate and voice. All right. So again, physiology, these are just basic information that I need you to keep in mind for the purpose of our lecture today. So what is the primary function of the pharynx? The primary function is airway protection. So we protect our airway by coughing or throat clearing to prevent any foreign object from going into the airway. So food, liquids, secretions, and whatnot. The second function is respiration, which is basically to maintain our airway open for breathing. So when we are not doing any phonatory function, when we're not voicing, when we're sitting at rest, when we're doing physical exercise, our vocal folds would rest in an abducted position to maintain our airway open and our larynx open to ventilate our lungs properly. Thirdly, vocalization, and you guys know that, vibration of the vocal folds to phonate. And lastly, the swallowing, and it serves as a food path, a passage for food to transition to the esophagus without penetrating the airway. Okay. So, start our topic today. What is a tracheostomy? So a tracheostomy is a surgically inserted tube in the trachea, and it's usually inserted below the vocal folds, and it's inserted sometimes between the second or third surgical ring, sometimes between the third and fourth surgical ring. And it creates like a clear passageway for air to enter the lungs properly. So who would benefit from a trach, and who would need a trach? If a patient cannot properly ventilate themselves and cannot maintain proper lung ventilation, probably due to an upper airway obstruction, maybe there's a tumor or stenosis, or if the patient is having lung failure or their lung collapsing and they need mechanical ventilation, then they would insert a trach into allow for proper ventilation, and so they would hook the mechanical ventilation to that trach. All right. So any question about trach and what is it and what's the purpose of it? All right. Okay. Okay, moving on. Coma patient. Yeah, so sometimes coma patient would have trach or intubation to allow for proper ventilation. Okay, moving on. So what are the parts of a tracheostomy? So a trach comes in so many different shapes and sizes, but almost all of them have a faceplate, which is this part over here. And it's usually on the outer, so it's visible from the outside. You would see it from the outside. It would have, this is an outer cannula over here. And the part that is usually inside the trach is called the shaft, which is this long part over here. This is a cuff, which is a sac attached to the shaft, and it's usually it will be inside the patient's trachea, and it's hooked to a pilot balloon, and this balloon would be resting on the outside of the patient's body. And what does this balloon do is that it helps inflate the cuff, whether using oxygen or water. It depends on the type of trach that the patient has on. This is an inner cannula, and it goes inside that outer cannula. So this is a dual cannula trach, but there are other kinds of trach where you would have a single cannula trach. And finally, this is a fenestration over here. And I just want you, I mean, we're not going to talk about the different kinds of trachs out there, but I need you to pay attention to what fenestration mean, because it's you know, it's going to help us when we explain later on the use of the speaking valve. So basically, fenestrated mean that the trach would have an opening or a hole on the shaft. And a non-fenestrated, it means that the trach does not have an opening or a hole. It's as simple as that. And I will explain why this is important to us as speech language pathologists later on when we're talking about speaking valve fitting. All right, so this is just a picture of different types of trachs. This is a single cannula pediatric trach. Over here is a non-cuffed, you don't see the cuff over here, non-fenestrated trach, doesn't have a hole at the back. This one is a non-cuffed, but it has a fenestration at the back for the inner and outer cannula. And this one is a metal trach. I don't think these trachs are used anymore. I think it's just one of the old models when trach were initially invented. All right, so what happens when a trach is inserted? So we just talked in brief about the pharynx and laryngeal physiology earlier. So when we breathe or when we inhale, the air is going through our nose and through our mouth into our trachea, and when we exhale, it goes back in the same way out of our nose and mouth. But once we insert a trach, that changes, because right now the patient is breathing through that trach. So when he inhale, the air is going through the trach and into the lung, and out of the trach and outside of the lung. So we no longer have any air circulating in that upper airway. So a couple of things happen when we bypass that upper airway in our breathing. Number one, we start losing our filtration system through our nose. So when we breathe through our nose, it usually humidifies and filters the air. So by the time it gets to our lung, it's warm and humid. So once we put on the trach, we lose 70% of that humidification and filtration system. So you would notice that the patient would start having a lot of secretions, trying to clear it with a cough and unable to clear it. The second thing that would happen is that the patient would have reduced sensation in the pharynx. So if you no longer have any air circulating in that upper airway, patient's sensation patient's pharynx would be desensitized. So patient will have reduced sense of smell, reduced sense of taste. They can no longer smell. They would tell you, oh, I can't smell your perfume, or I cannot taste that water, and so on. Thirdly, they would lose subglottic air pressure. So if we lose that subglottic air pressure, then the patient will be unable to phonate because we lose that vocal folds vibration, and the patient will not be able to cough as well. So we would lose the cough reflex. And as we said, we would have increased secretions accumulating over here, and patient would be having difficulty clearing those secretions out without coughing. Oops, sorry. I keep clicking on that type. And if we have reduced sensation, it means we will have reduced muscular movement. So if you don't sense the air, then if you don't sense air on your muscle, it means you won't have a motoric response or a muscular response. So it's going to affect the pharyngeal muscles, motoric responses and function. And if the patient is trached or intubated for a very long time, he hasn't been swallowing or moving his upper airway for a very long time, then the pharyngeal muscle might weakens and atrophies and decondition over time. So the laryngeal elevation, laryngeal squeeze could get affected during swallow as well. All right, so I'm just gonna go to presenters view, make sure I did not miss anything. Okay. Okay, so moving on. This is how a trach would look like from the outside. And this is a picture of a trach being suctioned. So as we said, that patient will not have that filtration system. They will have increased secretions. They will have reduced subglottic air pressure. They're unable to cough and clear out those secretions. So they might need some help with those suctioning, suctioning those secretions. This picture is of a trach hook into a ventilator, and you will see a lot of tubes coming out of the ventilators and hooked into that trach. And this little green thing over here is a speaking valve. Okay. If everyone doesn't mind the presenter view, sometimes I might shift to presenter's view. Okay, so someone had a question is, will they be able to phonate after surgery? Do you mean after the insertion of the tracheostomy? Is that what you mean? So if that's what you mean, initially they won't be able to phonate because, as we said, there will be no air going into that upper airway anymore. So there won't be any subglottic air pressure, no vocal folds vibration, so no phonation. Okay. So moving on. You guys, I don't mind if you would ask questions as I'm going. Directly related to dysphagia, it's more due to, okay, so someone is asking, I don't know if you guys can see each other's questions, but someone is asking that having a lot of secretions is not directly related to dysphagia, it's more due to lack of ventilation and weak cough. Yes, and in addition to probably the patient's respiratory status. So if the patient is unable to properly okay. All right. So the first question, yes, we will get to the differences between cuffed and uncuffed. Okay. So the first question was, will the patient be able to phonate after the surgery? And I'm assuming they mean after the surgical insertion of the trach. Initially, no, because probably after the surgical insertion, there will be a lot of swelling, a lot of bleeding, and their whole airway will be blocked, and a trach will be inside. And in addition to the fact that if the air is going through the trach and out of the trach and not going in the upper airway, not creating enough subglottic air pressure to move those vocal folds, then the patient won't be able to to phonate. The second question was, okay, so someone is asking if the trachs need to be changed or we can keep the same one. They do change the trach every 2 weeks for inpatients, but once a patient is, let's say he was discharged on a trach, sometimes they change it every month or every 2 months. So yes, it needs to be changed. And someone asked if having a lot of secretions is not directly related to dysphagia, it's more due to the lack of ventilation and weak cough. So it's both. So if it's not dysphagia per se, but if the patient, as we said, is lost his humidification and filtration, then they will have increased secretion. But again, if the patient has reduced respiratory function and has respiratory issues and difficulty clearing secretions out of their lungs, then they will have increased secretions. So it's not just the reduced humidification and filtration, but it's also the status of the lung and how sick that lung is. So it all depends on the patient's lung compliance, if that makes sense. Did I answer everyone's question? Okay. The pressure in cough matter in swallowing. So the pressure, you mean the pressure in cough in terms of, okay. So the pressure in the cuff, you mean this cuff, the cuff attached to the trach, or the pressure inside the airway? If you're talking about the pressure inside the airway, then we're going to discuss that as we go on. Okay, so the pressure inside, and someone asked about cuff and cuffless. So when we do speaking valve fitting and swallowing, we definitely prefer that cuff to be completely deflated. So we don't need that cuff, that little piece over here, to be inflated, okay? But the cuff inside of the trach, the pressure inside of the trachea does matter before deciding to put a speaking valve on or not. And we will get to that, inshallah. Okay, so let's talk about the role of SLPs. So our role is to reestablish verbal communication once a patient is on a trach or a ventilator, and to assess safety of swallow and rehabilitate swallow. And start this patient on oral feeding as fast as possible. So just keep in mind that once a patient is trached and ventilated, the ultimate goal is to get that patient decannulated or have that trach removed. So not all patients will be able to have their trach removed, but a lot do. And in order to do that, we need to restore that upper airway mechanism that was lost when we just talked about loss of subglottic air pressure, loss of upper airway circulation, a reduced cough, and all of that. And our ability to put on a speaking valve, restore phonation, start swallowing, moving those swallow muscles, definitely help in bringing that patient one step closer to decannulation or removal of that trach. And for those that unfortunately are not a candidate for decannulation or probably are going to stay on a trach or a ventilator for a very long time, then at least we can provide them with a better quality of life once we can start them on oral feeding or communication when they are on a trach and a vent. Okay, so who do SLPs work with? Okay, so we work in a multidisciplinary team that includes a primary physician, so the doctor that is in charge of the patient. It could be the ICU intensivist, it could be the otolaryngologist or the ENT. It really depends, but they really help you in determining if this patient is medically stable or you can start working on rehabilitation, or if they're still too sick for any SLP intervention. The second person that we work with is the respiratory therapist. And our respiratory therapist is the person in charge of making sure that this patient is properly ventilated, especially those with respiratory issues. In particular, those with respiratory issues. I'm working a lot in an ICU with ventilations and with tracheostomy. And they are a very, very valuable source for you guys to learn a lot from, especially when you're trying to make or base your clinical judgments of when to start oral feeding, when to put a speaking valve in correlation to the patient's respiratory status. So they are extremely helpful. The third person we work with is nursing, always. They will help you with suctioning the patients. You can give them your recommendations. They will make sure that the family or the patients are implementing your exercises, your recommendations, making sure that the patient is putting the speaking valve on, and so on. And we also work with a tracheostomy coordinator. So a tracheostomy coordinator is a nurse that continued their education to specialize in tracheostomy. So their job is to basically decide if this patient should be on the trach or not, if the patient can do they need to change the size of the trach, upsize the trach, downsize the trach, change the type of the trach, if they're ready for decannulation or not, which means decannulation means removal of the trach. Not all hospitals have tracheostomy coordinators or trach nurses. So if you don't have a tracheostomy coordinator, probably the decision of trach changes and upsizing, downsizing, and removal will be made by the ENT. And the trach change will be done by the respiratory therapist. But if you do have a trach nurse, then they will do both. They will change trachs, decide if the patient needs it or not, and decide if the patient is ready for decannulation or not. And of course, physical therapist, occupational therapist, and nutritionist. You guys know what all of these do. So we'll move on. All right. Before we start speaking valve, let me see the questions. Okay, so someone asked if we insert tracheostomy tube in our larynx are completely unable to phonate, or is it for a certain time period? So doctors don't insert a tracheostomy tube because the patient cannot speak. The doctors would insert a tracheostomy tube if the patient is failing to properly ventilate themselves. So the purpose of the trach to provide additional ventilation if the patient cannot properly ventilate themselves on room air, if that makes sense. So once that trach is inserted, it will impede the function of phonation, if that makes sense. Okay, so someone asked again, what's the difference between fenestrated and non-fenestrated? So I did show two pictures. Fenestrated means that the trach has a hole in the back, and non-fenestrated means that the trach has no hole in the back. And someone asked, what's our role in decannulation? And I will start talking about that right now. Okay. Okay, so in short, our role is restoring phonation and restoring swallow. And to restore phonation, we have to restore that lost upper airway mechanism, right? So we said that there are no upper airway circulation anymore when a trach is in. But when we fit a patient with a speaking valve, we restore that upper airway mechanism. And we will talk about the benefits of speaking valve in a minute. So what is a speaking valve? And this is how it looks like. It is a one-way valve that opens upon inhalation. So when a patient inhales, the air goes through the trach, and then it closes upon exhalation. So when the patient exhales the air, it seals and it redirects the air to come out through the upper airway. So through our nose and mouth, if that makes sense. Okay, these are just how different shapes of or versions of a speaking valve. This is a ventilated speaking valve. This is a trach speaking valve. And all of these are Apache-Muir valves, but other companies do manufacture speaking valves, such as Shally and Traco. But eventually they all do the same thing, which is restoring upper airway circulation. Okay, so I'm just going to show you a video to explain how a speaking valve works, okay? Okay, so now if we don't have the valve here, the air is going to go through the trach and out of the trach, right? Nothing is going to go through our nose and mouth and out of our nose and mouth, so no airway circulation here. So once we put that speaking valve here, this will happen. The air is going to go through the trach, and then when we exhale, the air is going to go below the vocal folds, restore that subglottic air pressure, and help the patient voice again, cough again, clear their throat again, regain sensation again. Okay, so when we close the trach, we do restore the complete mechanism, which is inhalation through nose and mouth and exhalation through nose and mouth. And when we open the trach, inhalation and exhalation is through the trach. But when we put the speaking valve, it's kind of like an in-the-middle solution where you would have an inhalation through the trach and exhalation through the nose. And it's for patients who are probably better than depending completely to breathe on a trach, but yet cannot sustain breathing through their upper airway completely, if that makes sense. Okay. So someone said that we see different colors of speaking valves. So the color doesn't matter, it's just about preference. We have some clear speaking valves because some patients don't like the speaking valve to stand out and they don't want people to see it. But the purple ones, the blue ones are the ones that we use in the hospital. So as healthcare providers, you can actually know that a patient is on a speaking valve when you walk into the room. So someone asked if the patient would sound normal or monotonous. So they should sound normal because you're restoring their own vocal folds function, but sometimes they might have hoarseness or breathiness depending on if there's any damage to that vocal folds. And we will talk about that in a minute. Oops. Okay, so what are the benefits of a speaking valve? So number one, restoring phonation, so the patient can talk again. But it does more than just phonation. So when you put a speaking valve on, you're restoring the upper airway mechanism, the one that was lost when we inserted that trach. So you're restoring sensation, so the patient is able to smell and taste. You're restoring subglottic air pressure, so the patient is able to phonate and patient is able to cough. And if the patient is able to cough, then they're able to cough those secretions accumulated over here. If you restore sensation, then the patient has better control over the food that they're swallowing, have better muscular movement, so it means it improves swallow and they would have a safer swallow. It also improves respiration and breathing. It does help in improving their lung in a way, not 100%, but it improves PEEP or restores PEEP. So what is PEEP? PEEP is the positive expiratory end pressure, which is basically the pressure that keeps our alveoli in our lungs open. So when usually the PEEP is created in the glottis and in different structures in the upper airway. So when you put a trach in, you lose PEEP, you lose that mechanism and pressure changes in that area. So PEEP is lost. So once you put the speaking valve back on and the airway circulation and mechanism is back and the pressure is back, you restore that PEEP, which means you improve that patient's ability to ventilate themselves through their upper airway. And you will see, like, let's say if the patient's saturation is 95 and you suddenly put the speaking valve on and you see their saturation jumping to 99, it means that their ventilation is improving. Okay. So someone asked if a person can be on a trach for a lifetime. Yes, some people do stay on a trach for a lifetime for different medical reasons. And we will talk about the candidacy as we go. And the whole of tracheostomy does heal. Once you remove that trach, it just takes a few weeks until the stoma closes. And yes, I can share the slides. Okay. Okay, so who is a candidate for a speaking valve? So that depends on multiple factors. So number one, the patient needs to be medically stable. And the primary physician won't probably refer the patient to you unless they're stable. So if you have any doubts if that patient is still too sick and have respiratory issues and still cannot breathe properly and they have increased respiratory rate, their saturation is too low, then probably they are not a candidate. Cognition. So if the patient is not alert or is very anxious and unable to follow commands, then the patient is not a candidate because they need to understand what you are doing and they need to express if they feel any discomfort if you put the speaking valve on. So secretions. So if the patient has a lot of secretions, they might not be a candidate for a speaking valve fitting, but there are no certain scales that can measure if secretions, the degree of secretions. So it's a subjective judgment. So sometimes you would go in and you would ask the nurse, oh, does he have a lot of secretions? And she would say, yeah, he has a lot of secretions. He's not a candidate for speaking valve. And then the next day you would go in and you talk to the respiratory therapist and he would say, well, he has medium secretions. So the point is, if the secretions are a lot to the extent that it's blocking the patient's airway, then that patient is not a candidate for speaking valve fitting. But if it's not too thick or it's not blocking, it's there, but it's not a lot, then that patient might be a candidate for speaking valve fitting. No upper airway obstruction. So if the patient has any tumors or stenosis in the upper airway, then probably they are not a candidate for speaking valve. Proper vocal fold function. So if the patient have a paralyzed vocal folds in the medial position that's occluding the airway, then probably he's not a candidate for speaking valve. And finally, tolerates cuff deflation. And we'll talk about cuff deflation in a minute, because it is very, very, very important to make sure that the cuff is completely deflated when you put a speaking valve on a patient. Okay. So what to consider when you're putting a speaking valve on? When you guys are asking, okay, we're gonna talk about when the patient is ready for a speaking valve, and what are the contraindications of a speaking valve. Okay, that's a very nice question, actually. Will there be a difference of quality, loudness in speaking valve while using index finger to close stoma or a speaking valve? So it depends. It depends on that amount of air that is escaping to the upper airway, and we're going to talk about that in a minute. But definitely, if you occlude with your finger, it means the patient right now is inhaling through his nose and exhaling through his nose. So he would have a better upper airway mechanism. So his voice, his swallow, his reflexes are going to be better. When you put a speaking valve on, it's an in-between kind of thing. So he's inhaling through the trach and exhaling through the mouth. So the voice shouldn't be that much different, but with some patient, it does make a difference. The voice might not be as good as when you're occluding their stoma. Or sorry, with their trach, I'm sorry. Okay. So someone is asking, if you use the speaking valve directly after inserted the trach, does that patient need any training to phonate while using the speaking valve or not? So we don't put a speaking valve directly after the trach is inserted, because as I said, it's surgically inserted. So sometimes that patient might have bleeding, might have edema, and probably he won't be a candidate for a speaking valve at that time. And we will talk about the candidacy right now, and it will make sense as we go. Okay, so what to consider when putting on a speaking valve. So the most important thing to restore that upper airway mechanism to allow for air to go back up. Oops, sorry, I keep doing that. Okay. Is to have enough space around the trach to allow the air to escape to the upper airway when the patient is exhaling. So if you put the speaking valve here, patient is inhaling, and then patient is exhaling, and you have that cuff fully inflated, then the exhaled air cannot escape to the upper airway. And the exhaled air will be causing CO2 retention. It means it will accumulate over here, and patient might actually suffocate. So there are so many things that could cause the air not to escape freely to the upper airway. So we need to make sure that the air is escaping comfortably without any pressure to the upper airway. So number one thing that we need to keep in mind is the size of the trach in correlation with the patient airway. What does that mean? So how big is that trach in comparison to that airway? So airway comes in different sizes and it differs from one person to another. In women, it's smaller than men, but even among women or among men, it differs. So you need to make sure that that trach has enough space around it to allow the air to escape to the upper airway, okay? And fenestration comes into play over here, that if the trach was not too small and does not have enough air escaping around it, if the trach has a hole in here, then it will allow the air to escape freely. I guess it will just give more room for the air to escape to the upper airway. So that's why we can never, never, never have a cuff trach, because if it's fully inflated, the air cannot escape freely. So patient needs to have a small trach in comparison to their airway. If it has fenestration, definitely better, because it will give more room for the air to escape, and the cuff needs to be fully deflated, okay? Secretions, if the patient has a lot of secretions that it's blocking the airway, then it will lead to the same thing. The air cannot escape freely as well. And cognition, as we said, the patient needs to be alert to express if they're suffocating or if they're desatting or if they're uncomfortable when you're putting that speaking valve on. So the secretions would probably accumulate sometimes on top of the cuff, sometimes on top of the trach, sometimes on the vocal folds. It will be all over the airway. Okay, moving on. So to make sure that the patient is tolerating the speaking valve, we need to make sure that there's enough room for the air to escape freely to the upper airway. We need to make sure that the airway is patent, okay? So how can we know that? How can we know if the size of the trach is not too large? How can we know that there aren't a lot of secretions that are affecting the airway escape to the upper airway? We usually do that through digital occlusion. And what that means is that you make sure, number one, that the cuff is completely deflated. You suction the patient if he has any secretions. You set the patient up properly to make sure that there is nothing blocking the airway. And then you put your finger against the opening of the trach. And you need to check if there is pressure against your finger. If you feel that there is some pressure against your finger, it means that the air is accumulating here and it's going inside the trach and pushing against your finger. It means there's something preventing it from escaping to the upper airway. And it could be because the trach is too large. It could be because the secretions are a lot, or it could be because there is some stenosis or blockage in the upper airway. And if you feel that there is pressure against your finger, then you need to think, okay, so what is the size of the trach? Is it fenestrated or not? If it's not fenestrated, then maybe it's a good idea to change this patient to a fenestrated trach to allow for more air to escape to the upper airway. Okay. Does that make sense? Or should I repeat this part? Okay, perfect. Okay, so now I'm going to show you a video of a speech therapist fitting a patient with a speaking valve. Okay. Can you hear the sound? The voice and the audio?
Yeah, a good day, Jay, so far. Yeah. Okay. So, let's get started. So, first, we're going to do a little bit of a presentation. So, 2, 3 big coughs.
Okay, so she's suctioning the patient to make sure that there are no secretions accumulating that could affect the speaking valve fitting.
Not a whole lot there. Pretty clear. Now, the other thing is we might have to suction you again after we get the cuff down. But you're going to feel air start to come up around the cuff, okay? Or up through your nose and mouth. And if you think that you have secretions that you might feel go by, you'll probably have to cough, and that'll be natural. If there was a lot, then we'd have to look at suctioning more.
And when you're deflating a cuff, you have to deflate to negative pressure. It needs to be deflated very, very well. It cannot even be partially inflated.
Take your cuff all the way down. It's very important to take the cuff completely down. You want to make sure it's totally empty. If it wasn't, we'd have a problem. 1, 2, 3, say off. Off. There's some.
Okay, so she just did the digital occlusion to sense if there's any backflow or pressure against her finger. The patient was able to voice and say ow, which just tells you that the air escaped to the upper airway. And sometimes if the patient is unable to voice, if he has issues with his vocal folds, just to make sure that the air is escaping freely, you can ask the patient to blow for you. You can bring a mirror next to his nose to see if there is some fog on the mirror, just to make sure that there is some air circulating into his nose and mouth, which means that the air is escaping into the upper airway.
Yeah, it's real soft though. Now I'm going to take this valve and place it onto your trach tube, okay? And that hopefully will give you enough boost to get that stronger voice. Are you ready? You've got just a little turn, and it's in place.
And I can talk.
And you can talk. Take a deep breath and cough for me if you can. There you go. Nice way to clear that upper airway.
And talk.
And talk.
That's it.
That's it?
That's it.
That's all you got to say?
I was looking at his red shoes.
You were looking at the red shoes.
Okay, someone asked about voice before with the speaking valve, about the quality of the voice. And if you noticed when she first put the speaking valve on, he had a hoarse vocal quality with some wet sounds. And that's probably because the secretions were pulled on top of his vocal folds. And then once she asked him to cough, he cleared those secretions out and his voice improved slightly. And you will notice as he starts talking, his harshness or hoarseness reduces and his voice improves. And that happens a lot with patients who have been on a trach for a very long time. So if you put a trach for the first time on a patient and there's no voice, that's okay, because probably this patient has been trached or intubated for a very long time, no airway circulation, his vocal folds haven't been moving for a very long time, his whole laryngeal muscles haven't been moving for a very long time. So it might need few hours or days to restore that function. So you need to monitor him over the next few days and see if there's improvement in his vocal quality. And if in a week or two no improvement, then you need to question if this patient is having any vocal folds issues or paralysis or something. So you might refer to an ENT to check his vocal folds.
The other benefits of this valve is to help you be able to eat and drink and taste and smell and have a better way to communicate with people. Work you up, or airway gets stronger there. Why do you like using the speaking valve?
Because I can't talk otherwise. And I have to have it to eat. I don't know what else you want me to say.
That sounds good.
Huh?
So someone said that speech therapists test secretions and air by finger and then put the tube and that's it. No, it doesn't. It's not that easy. So today I'm just sharing with you guys basic information, but how to assess a patient, how to approach a patient, how to decide if he's ready for a speaking valve or not, it involves a lot of other factors. It depends on the patient's medical status, diagnosis, kind of trach, size of trach, type of trach, if he's on a ventilator or not. Because if a patient is on a ventilator, you would have other consideration when you put a speaking valve on. Okay, so I like this question. If a fenestrated trach is more beneficial, then why do physicians use unfenestrated ones? Okay, so when a patient is on a ventilator, they need to create a proper seal to allow the mechanical ventilator to send all the oxygen in, and then read the information from the oxygen or the air coming out. But there are cuffed fenestrated trachs that sometimes the physician would put a patient on a cuffed fenestrated trach and inflate the cuff as long as he's on a ventilator. And once he's ready for deflation, we can start deflating and start the speaking valves trials. But sometimes some patient cannot tolerate the fenestration even if they're not on a vent, because it might cause granulation tissue. So basically, because it's an opening, sometimes it rubs or irritates the tracheal wall, and then it creates a granulation tissue that grows, and then it can basically occlude the airway or reduce the upper airway circulation and so on. So that's why they might use a non-fenestrated trach sometimes. But these are just some cases, and it's not everyone. A lot of patients would tolerate the fenestrated trach without getting granulation. But as you said, sometimes some physicians, it's just easy for them to put on a non-fenestrated trach than a fenestrated one. And then when we come and see the patient, we're like, oh, can he be on a fenestrated trach? And then he would decide if he can be on one and shift him to one. I'm not sure if that makes sense, but it's a little bit complicated. It depends on the experience of the doctor and the person inserting the trach. It's preferably yes. Suctioning can be done before deflating the cuff, yes, or after. It doesn't matter. But some people say that's a different topic, because some people think that a cuff would prevent aspiration, where in reality it does not. So that's why they suction. But you can do both. You can suction before or after the cuff. And if the patient does not have secretions, then don't suction. You never want to over suction, because you don't want to injure the patient's trachea or airway as well. Okay. So what are the contraindications? So inability to tolerate cuff deflation. So if the cuff is inflated, never, ever, never put a speaking valve on. Only if the patient can tolerate cuff deflation, or if a patient is on a cuffless trach. Some trachs come without a cuff, but if a patient is on a ventilator, then he has to be on a cuff trach until they can make sure that he no longer needs a ventilator machine, and then they can shift him to a cuffless trach. If the patient is unstable medically, and as everything, we're not approaching or starting any rehabilitative process if that patient is unstable medically. Severely compromised respiratory status. So if the patient's lungs are still too sick, if he has fibrosis or excessive secretions, then probably he's not ready for a speaking valve, because most probably if you put a speaking valve, you're just going to make his respiratory status worse. Severe anxiety and cognitive disorder. So if the patient is not accepting the speaking valve. Severe airway stenosis, as we said, if there's any tumor blocking the airway, preventing from the air to escape to the upper airway, if there's any stenosis, if the vocal folds are fixated in the medial position or paralyzed in the medial position, creating a total closure of the airway, then that patient is not a candidate for speaking valve fitting. And foam cuff trach. So as I said, there are so many different kinds of trachs out there. There are some trachs that had a cuff that is made of foam, and no matter how much you try to deflate a foam cuff, it will just re-inflate itself, whether with air or with the, because it's foam, it will suck the secretions around the trach, and then it will inflate itself. And then if you put a speaking valve on, then the patient might suffocate and desats. So if the patient is on a foam cuff, is not a candidate. You should wait until the patient is shifted to a normal cuff trach or a cuffless trach. Okay. How some tracheostomy patients can speak without speaking valve? Good question. So as we said, that sometimes if the patient trach is small enough in comparison to their airway, then they would have more air to leak around the trach, even if they don't have that speaking valve on. Some air can escape to the upper airway, and you would notice that the leaked speech that happens without a speaking valve comes and goes. It's not there continuously. It's probably because if the secretions is accumulated, patient would have difficulty voicing. If he doesn't have secretions, then he would have more space for the air to escape around the trach. So if his basically airway is large enough compared to his trach, and it's allowing air to escape to the upper airway, then they can speak without a speaking valve. But when you put the speaking valve, then you restore air to the upper airway. Basically, you have more air restoration to the upper airway. Does that make sense? During exhalation, all the air will escape to the upper airway. Unlike if you don't have the speaking valve on, some of it will go to the upper airway and some of it won't. Okay, so swallowing on trach. So it's very important before working with tracheostomy patients to have good basics of swallowing and swallowing disorders and dysphagia and rehabilitation. So I'm just going to discuss or talk about the basic swallowing phases. I'm sure all of you guys know that. The oral phase, which is some of them say it's the oral and oral preparatory. Some say it's oral preparatory, oral transport. So it depends on the author. But in the oral phase, we chew the bolus, we manipulate the bolus, we control the liquid, and we push the food or propel the food towards the pharynx. In the pharyngeal phase, there's the velopharyngeal closure to prevent food from refluxing to the nasal cavity. Closure of the larynx, which means closure of the vocal folds, closure of the false vocal folds, closure of the epiglottis. So we have 3 levels of protection of the airway. And then contraction of the pharynx and pharyngeal muscle to push the food down, elevation of the larynx, and then finally opening of the upper esophageal sphincter or the cricopharyngeus to allow the food to pass to the esophagus. Okay, and this is just different samples of what is a normal swallow versus an abnormal swallow. So this is a normal swallow, no aspiration, good velopharyngeal seal, good laryngeal elevation, no residue, good laryngeal squeeze, good pressure. This is an AP view. Again, no aspiration, passing nicely through their esophagus. Okay, and this is an abnormal swallow, and you can see the patient struggling. You can see him having difficulty with laryngeal elevation, no epiglottic deflection, no upper esophageal sphincter. It's not releasing, so the food is not going down, and of course aspiration. Okay. All right. Okay, so physiological changes with tracheostomy that affects the swallow. So it's the same thing, same altered mechanism. So when a trach is inserted, we lose the upper airway circulation. So we lose the subglottic air pressure. So we lose the vocal folds adduction during the swallow, the false vocal folds adduction. The muscles weaken, especially if the patient is trached on for a long period of time. The muscles atrophies. It affects the laryngeal elevation and it affects the epiglottis deflection. So you can see, so it increases the risk of aspiration. And because there is reduced sensation or desensitization in the airway, all of you can't hear me, or just one person? Okay. So, and because of that reduced sensation, then the risk of silent aspiration is very high, because patient won't be able to sense the bolus entering their airway during the swallow. So when a trach is in, we compromise the 3 levels of protection of the airway during the swallow. We compromise sensation as well. And because these patients are having respiratory issues, so a lot of them would have difficulty with coordinating, swallowing, and breathing. So research did show that trach patients do have high risk of aspiration, and the aspiration incidence with tracheostomized or vented patients fall between 50% to 87% of trach patients, which is a huge number. And 75% of them are silent aspiration. So you guys need to keep these information in mind when you're doing your assessments on a tracheostomized or vented patient. Okay, so what to consider when you are starting a swallowing assessment with a trach vented patient? You need to think, how long has this patient been in ICU? Because before this patient is referred to you for a speaking valve assessment or a swallowing assessment, they've probably been there in the ICU for 2 or 3 weeks, sometimes a month. So this patient has been trached for a very long time. His airway, he had no airway circulation in that area for a very long time. No muscular movement, laryngeal muscular movement for a very long time. So probably his muscles has atrophied and weakened. Not just his body, but also his larynx. History of intubation. So has this patient been intubated once or twice, or how long was his intubation? Just to think if there is any history of injury. Yes, and we have to consider the history of aspiration if this patient has a history of dysphagia before the trach. And if this patient might have tracheal or laryngeal injury because of intubation. And with sepsis, if patient ever had sepsis, just for you to think about the patient's immune system, his endurance level, and his safety during your assessment, and how alert is he. So level of protection so when we swallow, we have 3 levels of protection. So when we swallow, during the swallow, our vocal folds adduct to close shut, our false vocal folds adduct to close shut, and our epiglottis deflect to close our airway. So when we put a trach in and we lose the subglottic air pressure, then we lose all these 3 systems. So that's why this patient has high risk of aspiration. And we said that to consider if the patient has any history, any neurological or respiratory involvement. So if this patient had a history of stroke, history of neuromuscular diseases, history of respiratory issues, just to know if this patient had history of dysphagia or not. Okay. So does a speaking valve help swallowing? So since we know that when a trach is inserted, we lose the upper airway mechanism, and when we put the speaking valve on, we restore that upper airway mechanism, then we definitely restore sensation, we restore subglottic air pressure, we restore vocal folds closure, we restore the 3 levels of protection of the airway. So you set this patient up for a better swallow assessment. So if you assess the patient, so keep in mind, if you assess this patient for swallowing without putting a speaking valve on, and he has been trached for a very, very long time, no airway circulation, muscle weakness, atrophy, patient is weak, reduced endurance, then most probably he will fail the swallow assessment. But if you put the speaking valve on and you restore the upper airway mechanism, it's like you're rehabilitating that patient's swallow in a way, and when you're and it will improve the chances of having a better or a safer swallow. Now, do all patients need a speaking valve to have a safer swallow? No. Some patients do not require a speaking valve to be able to swallow, but in general, for patients who have been on a trach in the ICU for a long time and ventilator, it is better to put a speaking valve on. But in some cases, if the patient cannot tolerate a speaking valve, then you might jump to a swallowing assessment and see if the patient may pass or not. Okay. So candidacy for a swallowing assessment, medical and respiratory status. So patient needs to be stable medically and respiratory, and his respiratory status. So saturation should be above 90. His respiratory rate should be below 30. His heart rate needs to be within normal range. Cognitive status, patient needs to be alert to eat. So if the patient is not alert, if anyone was not alert and you feed them, they will aspirate. Tolerant of cough deflation. So it's very, very important to deflate the cough even when the patient is swallowing, because if the cuff is inflated and you ask the patient to swallow and you have that cuff sealing that airway, and then the patient would start swallowing and the larynx would start moving and elevating, then you could actually injure the patient's airway. So it's better to have the cuff deflated when you are assessing swallowing. Trach size, the smaller the better, and it's again because if the more air that can escape to the upper airway, the more airway circulation, the better sensation of the food bolus, so the safer the swallow it could be. And if safe feeding position is possible for patient, the coughing reflex is impaired, how we can evaluate patient correctly. Okay, I'm not sure. I don't think I understand your question. If safe feeding position is, I'm not sure. Okay, so let's just move on. So O2 requirement. So the more that the patient requires ventilation, it means that his respiratory status is not stable, which means his breathing, swallowing coordination might be affected. So he might be at high risk of aspiration. So if the patient on a very high O2 requirement or ventilator requirement, then maybe patient is not a candidate for a swallowing assessment. Toleration of speaking valve. So it's not a must, but it's recommended. So if the patient can tolerate a speaking valve, then the patient might do better in swallowing. But if he cannot, then you can go ahead and try and assess swallowing. Because in some cases where patient cannot tolerate a speaking valve for paralyzed vocal folds, their laryngeal function might be, or their laryngeal muscle might be intact, and they might have a safer swallow. Vent settings. So we did not talk about patients on speaking valve and swallowing on ventilators today because that's another topic. But not some patients on ventilator can tolerate oral feeding, but not all, and it depends a lot on the ventilator setting, their O2 requirement, and the size of the trach. And this is usually discussed and planned with the respiratory therapist. So what are tools for swallowing assessment? So we have subjective assessments and we have objective assessments. So we have our regular bedside swallow assessment where we try different consistencies, thin, nectar, puree, soft, solids, and hard solids. And we have the blue dye assessment. Are you guys familiar with the blue dye assessment or not? Yes. Okay. So just in short, it's basically assessing one consistency. You can choose whether thin or nectar. You can base that judgment based on the patient's condition. And you add blue dye, and then you suction the trach, and you can see if the blue dye came out of the trach. So if the blue dye came out of the trach, then the patient is probably aspirating. If it did not, then maybe his swallow is safe. However, research shows that 40 to 50% of blue dye assessment shows false negative, which means that you might feed the patient, suction, no blue dye, start patient on oral feeding, but then it turns out that the patient is aspirating. So for trach patient, knowing that they are at high risk of silent aspiration, as we said that 75% of those patients are silent aspirators, then I would not rely on a blue dye assessment on its own to start oral feeding. Would definitely recommend to go for an objective assessment. And if you can do that objective assessment with a speaking valve, then great. So you can either do a modified barium swallow study using video fluoroscopy, where you can give the patient different consistencies of barium and see if they pass on any consistency. They don't have to pass on all. They don't have to start full oral feeding. But if they can just have one consistency, puree or nectar to have with their tube feeding, then at least you restored some quality of life for that patient. Yes. And then you have the fiber optic endoscopic examination of swallow, which is endoscopy, where you scope the patient and you can give regular food and see if the patient is aspirating or not. So both assessments can tell you if the patient is aspirating or not, but with a modified barium swallow, the study is limited because you don't want to expose the patient to radiation. So you try few trials of each consistency, and that's it. But with fees, you have the room to actually do a full-on meal observation under fees and check how safe is that patient for a 15-minute meal or a 10-minute meal. Okay, so why is it preferred to do a swallow assessment with a speaking valve? So as we said in the slides before, so when you put a speaking valve, you're restoring the upper airway mechanism, right? So when you put a trach on, you lose the upper airway mechanism, you lose pressure, you lose subglottic air pressure, you lose sensation. When you put the speaking valve on, you restore these functions. And if you restore these functions, then you restore a safer swallow. So if the patient can sense better, then he can feel the food better, so he can swallow the food better without risk of aspirating. If he can have subglottic air pressure, then he can cough if he aspirated. He can have the 3 levels of protection of airway, which is the adduction of vocal folds, the true vocal folds, and the epiglottis during the swallow. Okay, so So when you do your swallowing assessment and you put the speaking valve on, then you assess the actual level of the patient's swallow function when they are having a closed system, which is a normal system. But if you don't put the speaking valve on, then you lose that upper airway circulation, so you don't have that enough pressure to swallow safely. So how long after inserting speaking valve do we assess swallow? Okay. It really depends on the patient. So once I put the speaking valve on and the patient has clear voice, good cough, good throat clearing, able to clear their secretions, then I would just assess him right away, because I know that he restored his upper airway functions quickly. But if I put the speaking valve on and the patient is having a weak cough, weak vocal quality, unable to clear his secretions, then I will probably wait a little bit, work on his voice, try to improve, do voice exercises, improve his vocal folds adduction to improve the cough, improve the expelling of the secretions, and then go from there and do the swallowing assessment. So last thing, I just wanted to show you like a video of both assessments of speaking valve and, fees with speaking valve and without, and modified barium swallow with speaking valve and without. Okay, so this is a short video, but I want you to pay attention to the without. You can see that he's trying to adduct his false vocal folds and vocal folds. It's creating bubbles, but it's not. He's unable to create to initiate the swallow. He's unable. Where in here, he's able to initiate a swallow. It's not a perfect swallow, but he's able to swallow safely. And this is a modified. So over here, you can see the patient, sorry, it's a very short video. You can see the patient is aspirating. It's affecting his elevation, his pharyngeal pressure. And over here, again, it's not a perfect swallow, but he's able to protect his airway. Some residue, but no aspiration. Okay. How long after inserting a speaking do we assess swallow? Okay. All right, so the takeaways from this presentation is tracheostomy affects the pharyngeal system, including phonatory and swallowing. Because we insert that trach and we disrupt the upper airway mechanism, then our voicing and our swallowing is affected with the trach. The speaking valve fitting does not only restore phonation, but it restores the upper airway mechanism. So if you restore that mechanism, you improve the patient's respiration, you improve the patient's phonation, and you improve the patient's swallow. And again, speaking valve fitting aids in improving swallow function, as we discussed. Speaking valve fitting and initiating oral feeding is a rehabilitative tool. So when you put a speaking valve on and you start the patient on oral diet, then you're bringing that patient one step closer to removing that trach. Because if you're restoring upper airway mechanism, then this patient is probably breathing independently without needing the full function of the trach itself, if that makes sense. Restoring the upper airway mechanism and swallow function contributes to possibility of decannulation. Restoring communication and oral feeding improves the quality of life for prolonged trached and vented patients. And that's it, but I wanted to share a few resources with you guys. If you're interested in tracheostomy, there are a bunch of courses and articles that you guys can read. This is a very nice article, Management of Communication and Swallowing in an Intensive Care. So it talks about swallowing in ICU on trach patients and patients without trach as well. It talks about the communication on a trach using a speaking valve, swallowing on ventilated patients, how does the ICU stay affect the patient's swallow overall, if that makes sense. And okay, over here, you guys still can see my screen, right? Okay. There are some nice free beginner courses at the Passimir Valve website. You can go to the Passimir Valve, you can go to clinicians, and you can press on free courses. And you will see some nice beginner courses over here, application of Passimir Valve. It's usually a 1-hour course, and it will help you, you know, start developing your theory and application of dealing with patients with tracheostomy and ventilator. Over here, courses about ventilator application for swallowing and Passimir valve. And they also have some nice resources, some nice articles. So if you go to resources, you can go to evidence-based, and then you can choose the topic you like. So if you can say communication and Passimir valve, it will open up a page with recommendation of different articles. And that's it. These are my references. So